ahead with the next talk by Dr. Dhanashree RATRA. She's from Shankar Netralaya, and she'll talk on the macrophages at the retina in diabetic retinopathy. Dr. RATRA.
Good evening, everybody. Thank you at the outset. Thank you for making me part of this wonderful session. So I'm going to talk to you about macrophage-like cells in the retina in diabetic macular edema. So no financial disclosures. So with the advent of optical coherence tomography, angiography, these macrophage-like cells have been shown to exist in the vitreoretinal interface over the internal limiting membrane in the retina. And these have been identified as retinal microglia. Now we know that these microglia are the innate immune cells which exist in all the layers of the retina. And basically they play a big role in the maintaining homeostasis in the retina. So microglia, when in the resting state, they are pro-survival, but when they are activated by some stimuli, they produce a lot of cytokines which can be neurotoxic. So this microglial activation is a common hallmark of many retinal diseases, and the opportunity to visualize these cells and study their behavior in vivo is unique. It can give us unique insights in the pathogenesis of several retinal diseases. And so this is a image showing you the phases in the microglial activity. So you have a resting stage in homeostasis, then you have the activation stage with the activation phase with the stimuli, and then they migrate to the area of the stimuli, the insult, and they become amoeboid, and they lead to phagocytosis, thus maintaining the homeostasis. So in order to visualize these MLCs in vivo, we take a OCTA scan, the 6 by 6 millimeter scan centered on the fovea using the Zeiss Cirrus 6000 machine with a good signal strength. And then the scan is manually segmented in the vitreoretinal interface at a slab 3 microns above the internal limiting membrane. And then this slab is exported to the ImageJ software for further analysis. Now, a stepwise semi-automated binarization protocol is used to extract and visualize this MLC macrophage-like cells. And here you see this in the last image. So these are the macrophage-like cells. So these are the cells actually, but very difficult to visualize them. So we have colored them red and then superimpose them on the angio image for better localization and topographic mapping of these cells. So so let us see what happens to these MLCs in diabetic retinopathy and diabetic macular edema. So we did a pilot study of 86 eyes of 86 patients and grouped them into eyes which had no diabetic retinopathy versus eyes with diabetic macular edema. And what we saw that the MLC activation was seen at distinct stages of diabetic retinopathy. The MLC density as well as the count increased with increasing severity of diabetic retinopathy. And nearly about 2 to 3.8 times increase was seen in these MLCs in cases of diabetic macular edema. And it was, again, it was correlated with the severity of the diabetic macular edema. The MLCs were seen clustered along the blood vessels, microaneurysms, and ischemic areas. And they were also significantly correlated with the glycosylated hemoglobin values. So these images, they show you the left side show the MLCs in the diabetic retinopathy, where you see very minimal images, and they are increased in the diabetic macular edema. So possibly the MLCs can act as biomarkers for disease progression in diabetic retinopathy and diabetic macular edema. So central foveal thickness and visual acuity are traditionally the two biomarkers which are used to measure the disease activity as well as the treatment response in diabetic macular edema. And what we saw that these MLCs showed significant correlation with both these biomarkers, indirectly telling that MLCs also can act as biomarkers for disease activity and possibly treatment response. So these images, they show that there is an increase in the MLCs in patients who did not undergo treatment for DME. At the follow-up visit, you can see much more MLCs in the patients who did not have treatment, whereas patients who underwent treatment and showed good treatment response, at the follow-up visit, you see there is a reduction in the MLCs. And this table just shows us that there is a significant difference in the MLCs in patients who underwent treatment from pre-treatment to after treatment. So can MLCs act as biomarkers for the DME treatment? To understand this, we did a regression analysis using MLCs and correlated them with various biological markers. We included several predictors such as lipid-related measures, that HDL, etc., then liver function test, hematological parameters, glucose tolerance test and blood sugar, oxidative stress markers, growth factors such as VEGF, basic FGF and PDGF, and inflammatory cytokines. We had a robust regression model with a very good significance level and association. And what we saw, surprisingly, that the VEGF was negatively associated with the macrophage-like cells. So what it means that when the VEGF macrophage-like cells increase, the VEGF level was seen to be reduced. And this indicates that in eyes with increased MLCs, the anti-VEGF driven response may be likely to be poor, because obviously there is no VEGF, so the anti-VEGF response might be poor. And these are probably the eyes which we call them as non-responders, and these are the eyes which we keep treating with anti-VEGF but without any response. And possibly they might be more candidates for intravitreal steroid treatment rather than anti-VEGF. And this finding was actually corroborated by a clinical study by Rangwani et al., where in the retinal vein occlusion study they found the increased MLCs were associated with thicker maculas, they were difficult to treat, they required more injections of anti-VEGF, and they had worse visual outcome. So this possibly indicates that the VEGF and MLCs, they are negative correlation. So how early does the MLC activation occur in diabetic retinopathy? So this is a graph from the neurological study, and in neurological studies such as Parkinson's and Alzheimer's, it has been shown that the MLC activation precedes clinical diagnosis of these disorders by nearly 10 to 15 years. So whether the similar thing is seen in diabetes was our hypothesis. We know that there is a state of pre-diabetes which exists nearly 3 to 5 years before the clinical diagnosis of diabetes, and nearly about 15 to 20 years before diabetic retinopathy. In an earlier study on pre-diabetes, we showed that there is a early neurodegeneration seen in pre-diabetes eyes without any overt structural changes. That means without any vascular changes or neurological changes, the functional changes were seen. Now in this study we looked at again MLCs in pre-diabetes, and what we saw that the MLCs, they did show excellent correlation with the multifocal ERG amplitude. They also had reduced foveal thickness. Although there was no structural changes, that means there were no structural changes in ganglion cell layer or RNFL, and there were no changes, vascular changes at all, but these early neurodysfunctional evidence was there. Apart from that, the multifocal ERG showed also topographic correlation with MLCs. That means the points of where the multifocal ERG amplitudes were reduced showed increased MLCs. So the MLCs, they not only predict neurodysfunction, but they are likely to even tell us the sites of future vascular changes, because in diabetic retinopathy it was seen that these areas which show reduced MFERG amplitudes will develop vascular changes about 3 to 5 years later. And here in pre-diabetes we are actually possibly predicting these sites nearly 15 years before the clinical changes can occur. So possibly MLCs can be precursor for these vascular changes. So to conclude, the non-invasive, label-free, in vivo visualization of the MLCs can help us understand the pathogenesis behind several retinal diseases, and MLCs can possibly act as disease biomarkers for diabetic retinopathy, as they show excellent correlation with the severity of diabetic retinopathy as well as visual acuity and central foveal thickness. The MLC showed negative correlation with VEGF. This of course needs further exploration, but it can help us explain the non-response that we see in certain patients. The activation of MLCs occurs at very early stage, even at the stage of pre-diabetes, which suggests that possibly early neurodegeneration occurs in pre-diabetes, and this possibly means that if we do some early neuroprotection, we might save some of the eyes from losing vision. So thank you very much for your attention.